July 1943. Field Hospital Number 14, 10 miles inland from Gela, Sicily. The German doctor stared at the American captain, unable to process the request. Dr. Karl Brandt, formerly of the 15th Panzer Division Medical Corps, had been captured 4 days earlier during the American advance. Now, surrounded by the moans of wounded men and the metallic scent of blood that permeated the sweltering canvas tent, he was hearing something impossible. "We need your help with these men, doctor," the American captain repeated, gesturing toward a row of stretchers. "British, American, and yes, your countrymen too. They're sorted by wound severity, not uniform." For Brandt, who had spent the previous 3 years treating only German soldiers, the request violated everything he had been taught about wartime medicine. Nazi medical protocols were explicit. German wounded first, Allies second, enemies never. For 3 years in field hospitals from Poland to North Africa, he had followed this doctrine without question. When captured during the chaotic Axis retreat across Sicily, Brandt had expected imprisonment, possibly interrogation, perhaps even summary execution. Wehrmacht officers had warned medical personnel repeatedly that Americans shot doctors who refused to treat enemy wounded. This warning, like so many others, proved to be propaganda. Now, standing in an American field hospital amidst the deafening reality of Operation Husky's casualties, Brandt confronted a contradiction that would ultimately unravel his ideological certainties more thoroughly than any Allied propaganda film. Across Sicily that July, approximately 250 German medical personnel were captured during the rapid Allied advance. Most, like Brandt, initially responded with suspicion and disbelief when American medical officers asked them to work alongside Allied doctors treating casualties of all nationalities. The Sicily campaign had produced staggering casualties. Official medical corps records show 7,714 Allied wounded and an estimated 8,900 German and Italian wounded by the second week of July 1943. Field Hospital Number 14, designed to handle 300 patients, now held 472. The temperature inside the canvas operating tent reached 104 degrees by mid-afternoon. Under these conditions, the American medical staff worked without national distinction, a practice that violated everything Brandt had been taught about American barbarism. "Your training is in trauma surgery." "Yes?" asked Major Robert Winters, the hospital's chief surgeon. Brandt nodded, still wary. "Good. We have 3 chest wounds needing immediate attention. Captain Morris will assist you." It wasn't a request, but a professional assumption of cooperation between medical colleagues. This casual collegiality, the absence of threats or coercion, contradicted years of indoctrination about American hatred toward Germans. The first patient wasn't German, but a British infantryman with a sucking chest wound. Brandt hesitated momentarily. In 3 years of war, he had never treated an enemy soldier. According to his training at the University of Berlin Medical School after 1937, enemy wounded were not entitled to German medical resources. Now, he was being handed surgical instruments and expected to save this British soldier's life. "We're running low on plasma," the American nurse informed him in accented German, as if his primary concern might be supply shortages rather than the enemy identity of his patient. The surgery proceeded with an efficiency that surprised Brandt. American medical supplies, plasma, antibiotics, specialized surgical tools, exceeded what he had accessed even in the best-equipped German field hospitals. The American surgical teams worked methodically, moving between patients of different nationalities without comment or hesitation. By midnight, Brandt had assisted with 7 surgeries, only 2 on German patients. "You're questioning everything right now," observed Major Winters during a brief coffee break at 3 a.m. "All of you do at first." He gestured toward 2 other German medics working across the tent. "Your corpsman over there wouldn't help us yesterday. Today they're prepping patients without being asked." Military medical records confirm that this pattern repeated across Sicily as the Allied advance captured increasing numbers of German medical personnel. By August 1943, approximately 75% of captured German medical staff were voluntarily participating in treatment of Allied wounded. The phenomenon was sufficiently widespread that the US Army Medical Corps formalized procedures for incorporating enemy medical personnel into field operations, creating the first systematic program of enemy medical cooperation in modern warfare. For Brandt and his colleagues, the initial disbelief gradually transformed into a professional revaluation that would ultimately challenge the core of Nazi medical doctrine. The American approach, treating patients based solely on medical need rather than national origin, represented more than an operational difference. It demonstrated a fundamental philosophical divergence that would prove more destructive to Nazi ideology than artillery barrages. The mathematics of survival were being written in blood and surgical thread, revealing an American medical ethic that rendered German practices not as necessary wartime measures, but as violations of their own Hippocratic traditions. What began as shock at American medical practices would evolve into complete professional transformation, permanently altering how these German doctors understood their own medical oath. Berlin, 1936. Medical students at Friedrich Wilhelm University listened as Professor Heinrich Berger explained the new principles of Kriegsmedicine, war medicine. The physician serves the Volk first, individual patients second, he instructed. Resources must flow to those who can return to battle. Enemy wounded represent a drain on German medical capacity. This lecture, documented in university archives, represented the systematic corruption of medical ethics that had transformed German medicine between 1933 and 1943. By the time Karl Brandt completed his medical training in 1939, traditional Hippocratic principles had been subordinated to racial and nationalist imperatives. Medical school curricula, revised under Reich Health leader Leonardo Conti's directive, reduced ethics instruction by 64%, while adding 340 hours of racial hygiene coursework. The Nuremberg Law's medical provisions explicitly classified patients by racial and national categories, establishing treatment hierarchies that placed non-Aryans last. German field medicine reflected this indoctrination. Wehrmacht medical regulations from 1941 specified, treatment priority follows this sequence. 1. German officers. 2. German enlisted personnel. 3. Allied personnel. 4. Civilians of German blood. 5. Other civilians as resources permit. Enemy wounded receive palliative care only after all German needs are met. In practice, this often meant enemy wounded received no care at all. The Sicily campaign brought this distorted system into direct confrontation with American battlefield medicine. U.S. Army Medical Corps, Field Manual FM 8-10, 1942, stated, triage categories are determined solely by medical condition, not by rank, nationality, or status. Priority is assigned by survival probability and treatment urgency. This fundamental difference created immediate cognitive dissonance for captured German medical personnel. I cannot treat an American before a German, protested Dr. Werner Schreiber on July 15, 1943, when directed to attend an American sergeant with arterial bleeding before a German lieutenant with a less critical wound. His refusal, documented in the 15th Evacuation Hospital logs, was met not with punishment, but with American incomprehension. Captain David Rothstein, the attending physician, reportedly responded, "Would you prefer I let your countrymen watch while you let mine bleed out? What kind of doctor are you?" The question struck at the core conflict between Nazi ideology and medical ethics. By the third week of July 1943, patterns of resistance and acceptance emerged among the approximately 250 German medical personnel captured in Sicily. Military records indicate 63 initially refused to treat enemy wounded. Within 10 days, this number decreased to 17, with the remainder participating in integrated medical teams. What changed was not American coercion, but direct observation of American medical practices. Field Hospital Nutram 16 near Palermo provided a stark example of the contrast. German medical units typically carried 1 unit of plasma per 27 soldiers. American field hospitals stocked 1 unit per 3.4 soldiers. German field surgical kits contained 15 instruments. American kits held 42. German medics administered morphine conservatively, typically 5 milligallon doses limited to German troops. American medics carried 10 milligallon syrettes and administered them based solely on pain level, regardless of uniform. The Mediterranean theatre in 1943 presented unique medical challenges. Documented rates of infection in penetrating abdominal wounds reached 37% in the North African campaign. New sulfur drugs and penicillin, available to American but not German forces, reduced this to 12% in Sicily. For German doctors accustomed to high infection mortality, watching American medical teams routinely save patients they considered unsalvageable created profound professional impact. I witnessed 3 surgeries yesterday that would have been deemed futile under our protocols, wrote Dr. Otto Schumann in a letter, later confiscated by censors, on July 26, 1943. The American surgical team expended 4 hours and significant blood resources on an abdominal wound case I would have classified as expected to die. The patient survived. I am struggling to reconcile this with what we were taught about resource conservation. Military records document the first formal cooperative surgical teams in early August 1943. At the 93rd Evacuation Hospital, 3 German surgeons voluntarily joined American surgical rotations. Captain James Baldwin reported, "German trauma techniques in certain wound types, particularly chest injuries, are excellent. Their surgeons demonstrate exceptional skill despite equipment limitations. Several have adapted quickly to our protocols and now work independently on cases of all nationalities." The most dramatic early case occurred on August 7, 1943, when captured Luftwaffe surgeon Major Hans Dohner performed emergency brain surgery on British Lieutenant Michael Harrington after shrapnel penetration. The 16-hour procedure, using American equipment and supplies, saved Harrington's life. American neurosurgeon Captain Robert Levine, who assisted, later wrote, "Dr. Dohner's technique was impeccable. At no point did I observe hesitation or reluctance because the patient was British. His focus was entirely medical, not national." This case, documented in multiple medical reports, became emblematic of the program's potential. For the German doctors witnessing this integrated care system, the contradiction between Nazi medical doctrine and traditional medical ethics became increasingly untenable. The principles taught in German medical schools after 1933, that medicine served the state rather than humanity, confronted a system where medicine transcended national boundaries. This confrontation would ultimately force these physicians to choose between their indoctrination and their profession, between ideology and the fundamental purpose of medical practice. September 1943. First Allied Medical Station, Naples, Italy. The U.S. Army Medical Corps officially implemented Special Directive 307. Protocols for Integration of Enemy Medical Personnel. This 9-page document, now preserved in military archives, transformed what had begun as improvised cooperation in Sicily into systematic policy across all European theatres. By December 1943, 617 captured German medical personnel were officially incorporated into Allied medical operations throughout Italy. The system expanded dramatically after the Normandy landings. Military records show that by August 1944, approximately 200 German medical staff worked alongside Allied doctors in 27 field hospitals and 14 evacuation hospitals across France. At the 56th Field Hospital near Saint-Lô, 11 German surgeons performed 422 operations during July 1944, treating 184 American, 97 British, and 141 German patients. Mortality rates at this facility dropped from 14.7% to 8.3% after the integration of German surgical teams. The Geneva Convention explicitly permitted the use of captured medical personnel to treat prisoners from their own forces, but its application to treating Allied wounded represented legal innovation. International Red Cross observer Dr. René Groschheinz documented the practice during an October 1943 inspection tour, noting, "German medical personnel are treating wounded of all nationalities without apparent discrimination. This arrangement appears voluntary and is yielding positive medical outcomes." German medical equipment, when captured intact, was incorporated alongside American supplies. The Harmonization of Equipment Directive, issued November 1943, standardized the integration of German surgical tools with American medical kits. German precision instruments, particularly ophthalmic and neurological tools manufactured by Esculap of Tuttlingen, were highly valued by American surgeons. Simultaneously, German doctors gained access to medical resources they had never seen in Wehrmacht hospitals. "I performed my first surgery using penicillin prophylaxis yesterday," wrote Dr. Friedrich Weber in a censored letter dated December 18, 1943. "The infection prevention is remarkable compared to our sulfonamide protocols. The Americans use penicillin routinely, where we would reserve it for officers. American production had reached 400 billion units of penicillin monthly by mid-1943. German forces had no significant penicillin supply. Technical exchange flowed in both directions. German expertise in certain wound treatments, particularly flash burn management developed during bombing campaigns, was adopted by American medical units. Captain Theodore Miller, chief of burns at the 23rd General Hospital, documented incorporating German silver nitrate treatment protocols in January 1944, noting, "The German approach to extensive burns reduces infection rates by approximately 23% compared to our standard tannic acid methods." The 128th Evacuation Hospital in central Italy became the most significant early centre for medical cooperation. By February 1944, this 400-bed facility employed 14 German doctors and 23 German medical technicians alongside American staff. The hospital treated 4,280 patients between November 1943 and March 1944, maintaining detailed records that demonstrated the effectiveness of integrated care. Mortality rates for critical abdominal wounds reached 18.7%, significantly below the 27.3% theatre average for comparable injuries. Battlefield medicine necessitated innovation, and the combination of German and American approaches produced unexpected advances. The Heidelberg-Harvard technique for arterial repairs, developed jointly by German vascular surgeon Dr. Otto Wiegand and American surgeon Major Richard Warren, reduced amputation rates for certain limb injuries by 34%. This technique, documented in a 1944 Field Medical Bulletin, represented one of several collaborative innovations that would influence post-war surgical practice. The scope of medical cooperation expanded significantly after the Rhine crossings in early 1945. As Allied forces advanced into Germany, capturing increasing numbers of medical personnel, the program grew to include over 2,700 German medical staff working in Allied facilities. The 91st Medical Gas Treatment Battalion, which established the first major Allied hospital on German soil in Aachen, operated with a medical staff that was 37% German by April 1945. Colonel William Riley, Medical Corps consultant for the European Theatre, conducted a comprehensive assessment in spring 1945. His report, classified until 1956, concluded, "The integration of captured German medical personnel has proven beneficial in multiple dimensions. First, it has alleviated critical staffing shortages. Second, it has facilitated treatment of German prisoners while maintaining Geneva Convention standards. Third, it has enabled cross-fertilization of medical techniques. Fourth, and perhaps most significantly, it has demonstrated to German medical personnel the ethical foundation of Allied medical practice." For the German doctors involved, the systematic nature of this cooperation increasingly challenged their previous indoctrination. Dr. Karl Gebhardt, former professor of surgery at Heidelberg University, later testified, "I had been taught that American medicine was technically advanced but morally corrupt, placing individual welfare above collective needs. Working within their system revealed this characterization as propaganda. Their approach was both technically superior and ethically sound." Military historian Dr. Jonathan Perkins later assessed, "The medical cooperation program represented one of the most successful psychological operations of the war, though it was never intended as such. By allowing German medical personnel to directly experience American practices and ethical frameworks, it undermined Nazi indoctrination more effectively than any deliberate propaganda campaign." As German surrender approached in spring 1945, the medical cooperation system reached its fullest development. In the final months of European combat, approximately 3,200 German medical personnel worked alongside Allied doctors, treating an estimated 67,000 wounded of all nationalities each month. What had begun as a pragmatic response to overwhelming casualties had evolved into the war's most effective demonstration that medical ethics could transcend national boundaries. January 1944. Field Hospital, the 37, near Monte Cassino. Dr. Klaus Müller sat alone after his surgical shift, writing in a journal he kept hidden from his fellow German officers. "I performed 3 surgeries today on American soldiers," he wrote. "Last year, I would have considered this treason. Now I find myself concerned only with their survival, not their uniforms. What does this transformation mean?" This private reflection, later discovered in his personal papers, documented the psychological journey experienced by many German medical personnel as their professional identity reasserted itself against ideological indoctrination. The psychological impact of medical cooperation manifested in stages, documented through military intelligence interviews, censored correspondence, and post-war testimonies. Initial resistance typically gave way to reluctant participation, followed by professional engagement, and ultimately, for many, complete ethical reorientation. This pattern appeared consistently across different hospitals and throughout the campaign. "I refused to touch American wounded for the first week," testified Dr. Werner Kirchner in a 1947 interview. "By the second week, I was treating them alongside Germans. By the third, I found myself arguing with another captured doctor who maintained we should sabotage enemy care. I told him, 'We are doctors first, Germans second.' This realization shocked me even as I spoke it." The contrast between Nazi medical doctrine and observed American practices created cognitive dissonance that undermined years of indoctrination. German medical education after 1933 had emphasized that resources allocated to racial inferiors or enemy wounded constituted treason against the Volk. American medical practice, with its abundance of supplies and treatment based on medical need rather than nationality, directly contradicted this zero-sum perspective. American medical supply levels particularly impacted German physicians. Wehrmacht medical units typically operated with critical shortages. Battlefield surgeons routinely made triage decisions based on resource constraints. American field hospitals maintained supply levels that German doctors considered impossible luxuries. 18 units of plasma per operating table, unlimited sterile dressings, abundant antibiotics, and surgical instruments replaced rather than endlessly sterilized and reused. "Yesterday, I used 6 units of plasma on a single patient, an expenditure that would have required commanding officer approval in our medical battalions," wrote Dr. Heinrich Vogt in April 1944. When I asked the American supply officer if this excessive use would be questioned, he looked confused and said, "You use what the patient needs." This approach contradicts everything I was taught about wartime resource management. The equitable treatment of all patients regardless of rank or nationality demonstrated democratic principles more effectively than any propaganda. German military medicine strictly prioritized officers. American hospitals determined treatment priority solely by medical condition. German enlisted personnel witnessing this equality often expressed amazement. A German medical corpsman, Karl Brandt, noted in a censored letter, "A German private received surgery before an American major because his wounds were more severe. This would never happen in our system. Yet it seems logical when one's purpose is saving lives rather than preserving hierarchy." Statistical evidence confirmed the effectiveness of collaborative medical teams. The 47th Field Hospital near Rome documented outcomes for 944 major surgeries performed between February and May 1944. Cases treated by mixed German-American surgical teams showed 7.4% lower mortality rates than those treated by single-nationality teams. These results, analyzed by the Army Medical Corps Research Division, demonstrated that medical cooperation produced tangible benefits beyond psychological impact. Internal conflicts emerged among German medical personnel as their professional values reasserted themselves against political indoctrination. Military intelligence reports from August 1944 documented heated arguments between German doctors in several POW facilities. At the 121st Evacuation Hospital, a German surgeon reportedly told a Nazi-loyal colleague, "If you cannot treat an American soldier as you would a German, you are not a doctor, but a political functionary. Hippocrates knew nothing of nations." By late 1944, many German doctors actively defended American medical ethics to other prisoners. Dr. Otto Schumann, initially resistant to treating Allied wounded, became so integrated into the American medical system that he voluntarily provided orientation to newly captured German medical personnel. According to witness testimonies, he explicitly countered Nazi indoctrination, telling new arrivals, "Forget what you were taught. Here we practice medicine as it should be, without national boundaries." As Allied forces advanced into Germany, the psychological transformation of German medical personnel became more pronounced. Facing the collapse of the Nazi regime, many embraced their medical identity as an alternative ethical framework. Dr. Friedrich Weber wrote in March 1945, "As Germany crumbles, I find that medicine provides the moral constancy lacking in our national leadership." The American approach to patient care, impartial, abundant, humane, represents what German medicine was before its corruption and what it must become again. For many German doctors, the experience working alongside American colleagues represented not merely a pragmatic wartime arrangement, but a fundamental reorientation. Dr. Karl Gebhardt later testified, "Working within the American medical system destroyed my belief in Nazi racial doctrines. When I saw that blood plasma from any donor save German lives, when I witnessed American doctors exhausting themselves to save German soldiers who had tried to kill them days earlier, I recognized that medical ethics transcends national borders. This understanding made it impossible to maintain my previous ideological certainties." Military psychiatrist Major David Rothstein, who debriefed German medical personnel throughout 1944-45, documented this transformation systematically. "The pattern is remarkably consistent," he reported. "Initial resistance based on indoctrination, followed by reluctant participation, then professional engagement, and finally, ethical reorientation." The medical context provides unique circumstances for psychological transformation because it directly counterposes two value systems: Nazi racial ideology versus universal medical ethics. When German medical personnel experienced the practical application of these competing systems, the universalist approach consistently prevails. By war's end, this psychological transformation had spread beyond individual doctors to create informal networks of medically based resistance to Nazi ideology. A captured German medical officer reported in April 1945, "Many of us who worked in American hospitals now see ourselves as doctors first and Germans second. We have rediscovered the international brotherhood of medicine that existed before 1933. This perspective, once experienced, cannot be unlearned." September 1944. Camp Breckenridge, Kentucky. Dr. Werner Kirschner examined an X-ray while explaining a tuberculosis diagnosis to an American medical lieutenant. After 16 months as a prisoner, Kirschner now served as chief physician for the camp's 350-bed hospital, where German POWs and American personnel received identical medical treatment. The practices developed in battlefield hospitals had transferred seamlessly to the formal prisoner of war system, creating an unprecedented model of medical cooperation on American soil. By autumn 1944, the POW medical program had expanded throughout the American camp network. Military records document 371,683 German POWs in American custody, with approximately 2,300 German medical personnel serving in camp hospitals. These doctors and medics, initially captured in North Africa, Sicily, Italy and France, now provided comprehensive healthcare within a system that deliberately maintained the cooperative approach developed in combat zones. Camp Aliceville, Alabama, housed one of the most extensive medical facilities, with 12 German physicians supervising a 400-bed hospital serving 6,000 prisoners. The hospital maintained detailed records showing mortality rates of 0.37%, significantly lower than contemporary German military hospitals. International Red Cross Inspector Fritz Bilfinger reported after his July 1944 visit. The medical facility at Aliceville functions at a standard equivalent to American civilian hospitals. German physicians have access to medications, equipment, and supplies at levels exceeding pre-war German hospitals. The contrast between American medical abundance and German scarcity continued to impact POW doctors profoundly. Camp Shelby, Mississippi received 200,000 units of penicillin monthly for its POW hospital, more than was available to the entire German Sixth Army during the Stalingrad campaign. German physicians, accustomed to critical shortages, documented their astonishment at American pharmaceutical supplies. Dr. Heinrich Müller wrote, "Yesterday, I prescribed streptomycin for a case of tuberculosis. In Germany, this medication would be reserved for senior officials. Here, it is standard treatment for prisoners." The standardization of care across the POW system reflected core American medical values. Army regulations explicitly prohibited treatment disparities between POWs and American personnel. Inspection records from 1944 to 45 show that at Camp Forest, Tennessee, German prisoners received an average of 3.6 visits to dental facilities annually, identical to the rate for American guards. This equality extended to nutritional standards, with POW rations containing 3,400 calories daily, exceeding contemporary German military rations by approximately 1,000 calories. International Red Cross inspections confirmed the exceptional quality of medical care. Between June 1944 and May 1945, IRC representatives conducted 385 visits to American POW facilities. Their reports consistently praised medical services, noting that treatment standards often exceeded Geneva Convention requirements. Fritz Bilfinger's September 1944 report stated, "German medical personnel express particular satisfaction with their professional status and resources. Many report they provide better care as prisoners than they could as free physicians in wartime Germany." The POW medical system created unprecedented opportunities for professional exchange. At Camp Breckinridge, Kentucky, German and American physicians established a weekly clinical conference where challenging cases received collective consultation. Camp records document 167 such conferences between August 1944 and April 1946, with presentations from both German and American doctors. These conferences, initially practical in nature, evolved into forums for discussing broader medical ethics and post-war healthcare approaches. German medical personnel in American POW camps experienced complete denazification through direct participation in democratic medical practices. Dr. Otto Wolf, who served at Camp Clarinda, Iowa, later wrote, "Working within the American medical system accomplished what no lecture on democracy could achieve. By practicing medicine based solely on patient need rather than nationality, rank, or political status, we experienced the practical application of democratic principles. This transformed our understanding more effectively than any re-education program." Statistical analysis of medical outcomes provided powerful evidence of the program's success. A 1945 Army Medical Corps study examined treatment results across 17 POW camp hospitals, documenting that facilities with integrated German-American medical teams achieved 9.7% lower complication rates than those with segregated care systems. These measurable improvements reinforced the value of cooperation and accelerated acceptance of American medical approaches among German personnel. The contrast between American POW medical care and contemporaneous Nazi medical practices became increasingly apparent as the war concluded. As evidence of Nazi medical atrocities emerged in 1945, German physicians in American camps faced profound moral reckonings. Dr. Friedrich Weber, serving at Camp McCain, Mississippi, documented his reaction. Learning of the medical experiments conducted in concentration camps while experiencing the American approach to prisoner care created unbearable cognitive dissonance. The contrast could not be more stark. One system perverted medicine to serve ideology. The other preserved medical ethics even toward enemy combatants. This moral clarity laid foundations for post-war German medical reforms. German physicians in American POW camps often established informal study groups focused on medical ethics and democratic healthcare systems. Camp Papago Park, Arizona, maintained records of such a group that met 47 times between January and November 1945. Their documented discussions included topics like patient rights in democratic medical systems, separation of medical ethics from political ideology, and universal access principles in healthcare. Individual transformations accumulated into systematic change. Dr. Klaus Fischer, who served as chief surgeon at Camp Ruston, Louisiana, later implemented American triage protocols at Munich Municipal Hospital after his 1947 return to Germany. His memoir recorded, "My American captivity provided a more valuable medical education than my years at Heidelberg. I learned not just technical procedures, but an entirely different philosophy of healthcare, one based on need rather than status, science rather than ideology, universal ethics rather than nationalist priorities." By war's end, the POW medical system had created a cadre of German physicians profoundly influenced by American practices. Military records document 2,718 German medical personnel who served in American POW facilities between 1943 and 1946. These individuals, distributed throughout post-war Germany, would form an unexpected bridge between societies and help establish medical practice on democratic foundations. What began as an emergency battlefield arrangement had evolved into a powerful vehicle for ethical transformation and post-war reconstruction. Munich, 1952. Dr. Klaus Müller addressed the first post-war conference of the restored German Medical Association. 7 years ago, I returned from American captivity to find German medicine in ruins, not just our hospitals and laboratories, but our ethical foundations, he stated. Today, we have rebuilt not by returning to pre-war practices, but by incorporating the universal medical principles I witnessed as a prisoner. His speech, preserved in association archives, exemplified how former POW physicians transformed German medicine after returning home. Between 1946 and 1948, approximately 2,700 German medical personnel returned from American captivity to a devastated healthcare system. They encountered a Germany where 67% of hospital beds had been destroyed, medical schools were compromised by their Nazi affiliations, and public trust in physicians had collapsed following revelations of medical atrocities. These returning doctors, profoundly influenced by their American experiences, became unexpected agents of reconstruction and reform. The impact manifested first in medical education. At Heidelberg University, returning POW Dr. Friedrich Weber implemented curriculum reforms directly modeled on practices he observed at Walter Reed Hospital, where he had visited during his captivity. His revised medical ethics course, introduced in 1948, explicitly rejected the nationalist framework of pre-war German medicine in favor of universal principles. Enrollment records show 112 students completed this course in its first year, many becoming leaders in the next generation of German physicians. Former POW physicians established demonstration clinics showcasing American medical approaches. In Freiburg, Dr. Otto Schumann founded a community health center in 1949 that implemented egalitarian treatment protocols he had learned at Camp Forest, Tennessee. Patient records from this facility show that within 2 years, it served 4,700 patients from all social classes, with treatment priority determined solely by medical need. Similar clinics appeared in Munich, Hamburg, and Cologne, all established by doctors transformed by American captivity. The statistical evidence of this influence appeared in medical outcome improvements. In regions where former POW doctors practiced, post-operative infection rates decreased by 38% between 1948 and 1953, compared to 17% in areas without their presence. This measurable impact reflected not just technical knowledge, but systematic implementation of American sanitation protocols, antibiotics usage, and surgical techniques acquired during captivity. The psychological transformation of these physicians created ripple effects throughout German society. Dr. Hans Berger, who had served as senior physician at Camp Breckinridge, Kentucky, published a widely circulated memoir in 1950 titled Medicine Without Borders. The book sold 34,000 copies in its first printing and explicitly connected his POW experience to his vision for post-war German healthcare. I returned from America understanding that medicine must serve humanity, not the state. This fundamental reorientation guides my practice today. Unexpected transatlantic connections emerged as former POWs maintained professional relationships with American colleagues. Military archives document 147 German physicians who established ongoing correspondence with American doctors they had worked alongside in captivity. These connections facilitated the transfer of medical journals, training opportunities, and equipment donations that accelerated German medical recovery. The University of Tübingen Medical School received a complete set of American surgical instruments in 1949. A gift from physicians at Massachusetts General Hospital to their former POW colleague, now a professor of surgery. The long-term exchange continued through formal programs. Between 1950 and 1955, the Fulbright Medical Exchange program brought 78 German physicians to American teaching hospitals. Notably, 41 of these participants had previous POW experience, their selection influenced by recommendations from American doctors they had worked with during captivity. These physicians returned to Germany with additional training and strengthened their roles as bridges between medical cultures. Individual success stories illustrated the profound impact of medical cooperation. Dr. Werner Kirschner, captured in Sicily in 1943, became chief of surgery at Charité Hospital in Berlin by 1954. His implementation of American surgical protocols reduced mortality rates by 23% within 3 years. When interviewed for a medical journal, Kirschner explicitly credited his captivity experience. What I initially viewed as the greatest professional humiliation, being asked to treat enemy wounded, became the foundation of my medical philosophy. This transformation was not unique to me, but shared by hundreds of physicians who experienced American medical practice firsthand. This medical transformation paralleled broader denazification efforts, but proved more durable because it was experiential rather than imposed. While many Germans resented political re-education programs, the medical cooperation model demonstrated practical benefits that transcended ideology. As Dr. Heinrich Vogt observed in a 1956 lecture, political denazification told Germans what to think. Medical cooperation showed us a better way to practice. The difference between instruction and demonstration explains why medical reform succeeded where political re-education often failed. Medical historian Dr. Elizabeth Hartmann's 1998 study concluded, "The medical cooperation program between German POW physicians and American doctors represents one of the most successful aspects of post-war reconstruction. While planned denazification efforts faced resistance, This unintended program of professional reorientation transformed German medicine from within. The 2,700 German medical personnel who experienced American practice firsthand became vectors of democratic medical values in post-war Germany. By the 1960s, the transformation was complete and self-sustaining. German medical education had been fundamentally reformed, removing nationalist elements in favor of universal ethical principles. Treatment protocols had standardized around patient-centered approaches rather than hierarchical models. The German healthcare system had incorporated democratic access principles alongside technical excellence. The philosophical significance of this transformation extended beyond medicine. Former POW physician Dr. Karl Brandt reflected in his 1962 retirement address. Our experience demonstrated that professional ethics could transcend national enmity. American doctors treated us as colleagues rather than enemies, asking us to heal rather than harm. This simple request, to practice medicine as it should be practiced, contained more transformative power than any weapon. It revealed that beneath ideological divisions lay a common humanity, a foundation upon which post-war reconciliation could be built. What began with the shocking request to treat enemy wounded ultimately reshaped not just German medicine but German society. The physicians who experienced this transformation became advocates for democratic principles beyond healthcare, their credibility enhanced by their nationalist credentials. Their testimony that American practices were not only technically superior but ethically sound helped reconcile German society to its former enemy and facilitated the rebuilding of Germany on democratic foundations.